Good evening, everyone. Welcome to Unacademy, where you can crack all NEET PG exams with us, with our top educators, quality content, and of course, have a great learning experience with us. A little about me. I'm Dr. Sasha Menon Remedies. I've done my MD in Anesthesia from Father Muller Medical College, Mangalore, and I have 2 publications and 1 paper presentation in the field of anesthesia. And I have been working and teaching in Bangalore for the past 2.5 to 3 years. Now today's topic will be Capnography Part 2. Now yesterday we dealt with Capnography Part 1, right? So today we'll be completing the topic, and I hope we'll try to, if time permits, we will revise yesterday's topic too. Or maybe I will revise yesterday's topic first and then we can continue with today's topic, so that there is a flow for you all anyhow, uh, whichever which way, right? So this is today's topic, Capnography Part 2. Sorry, just checking whether we're streaming live or not. We are. So a little about Unacademy now. It's one of India's largest online learning platform, where you get plus subscription and access to unlimited live and recorded courses from India's best educators. Now, what will you get out of Unacademy? So basically, we have our daily live classes where you can chat with your educator, engage in discussions, clear your doubts, and answer polls. And all this is while the class is going on. So basically, sorry. So now, when you go to a coaching institute, basically in a coaching institute, you have to. You have to get up, you have to get ready. There's a lot of energy waste, time waste. Then you reach your coaching institute, then you need to get your place. You have to reach early, otherwise you'll get some other place. You might not get an optimum place, where you can catch the educator's attention when they're teaching, if you need to clear it out. So all those problems are there. Then again, your educator, it's very difficult for your educator to clear everyone's doubts, right? It's a large class and he or she has a time frame to finish class and all that. But over here on Unacademy, while we are teaching, you can ask your doubts. So you don't really break our flow of teaching, right? So you can ask your doubts, we clear it during the class or after the class, whenever possible. These are all structured courses. So they are all structured and they are in line with your exam syllabus, and they help you best prepare for your exam, right? So these are all courses which are prepared, uh, keeping your interests in mind, best interests in mind. So these are all that which will help you best prepare. Then we have our live tests and quizzes, so which will help us evaluate your preparation, help you evaluate more than us evaluate your preparation. So we have mock tests, quizzes, and these will give us a detailed analysis on your performance. And then we have unlimited access. So one-time subscription gets you access to all our live and recorded courses, and you can watch them from the comfort of any of your devices. So it's just one subscription wherever you are, whether you're traveling, whether you're in your hostels or in your house, wherever you all are, whether you're using your phones or iPads or tablets, wherever you all are, you'll have access to all the live and recorded courses to watch from the comfort of your device. So these are some of our top educators. Dr. Nikita Nanvani, she's a PG mentor for radiology as well as mnemonic concepts, and focusing on must-know topics, which encompasses almost all subjects. So these are mnemonics are very important. So what madam is doing is it's really nice. It will help you all to do login and for her mnemonics, but also remember that your own mnemonics are very important, because it will help you remember better rather than learning what someone else has made. So it will help you remember better when you make your own mnemonic, because you form a pattern of learning. Basically, it's very important. All that you have to do is practice, revise, practice, revise. Practice basically test papers, revise, test papers, revise. Dr. Mohammad Azam, Dr. Divish Mishra, and Dr. Kriti Sharma. These are some of the courses offered. Now, as you can see, there are about 19 subjects that are here and various courses under each of these subjects. Now, as you can see, topics like anesthesia, psychiatry, radiology, and all that, you'll never paid much attention even during MBBS, right? They were known as the smaller subjects because you all didn't have to do there was not much time allotted to them, but frankly these are huge subjects. There's a lot to cover under these subjects, and it's actually, you all just did the cream of the cake. So mostly they'll also ask you the cream of the cake. It's just the basic stuff that they will ask you. So so that's what I'm trying. I'm trying to do that here. I will stick to what is needed for you all, best the topics that are need to be covered. Of course they have said that almost all the topics have to be covered, but it's such a vast subject. So, and for your, of course your, and only 11 marks are awarded, so it's basically the most common frequent asked questions that will be there. And of course you have anatomy, physiology and all, those are like 44 marks each subject, so you will have to go into detail with those subjects. But with these subjects you need to concentrate, focus, don't lose your marks with these small subjects. Small in the sense because they are of allotted less marks, they're very scoring. Then these are some of the ongoing courses on our platform. That is course on neurophysiology, GI surgery, cardiovascular thoracic surgery, course on pathology, respiratory system, course on larynx. Now coming to the subscription. Now this is our subscription. So as you can see, there is 1, 3, 6, 12, 24 months. So those who are planning to give the NEET PG this year, 6-month subscription should suffice for you all, but others I would highly recommend you all go for the 12 and the 24-month subscription. Now when it comes to these subscriptions, firstly, like I said, those subjects which we weren't really exposed to during our undergraduation, those are like we call them the smaller subjects, right? So you're not very much exposed to the subject, so it's a little difficult. You don't know what to subject, the content, right? So when you are studying, maybe you've made up your mind about medicine or orthopedics or something. When you're studying these subjects, you might realize, oh, I actually want to take up this subject. I actually want psychiatry. I like it. I'm enjoying what I'm studying. So it's very important. You might not be exposed to the practical aspect of it, but it is very important to like what you're doing, right? So you have to read that for the rest of your life. You have to study that. This will be your bread and butter. So you need to like what you do. So this time will actually give you time when you're preparing to help think too, because you're in the subjects. Of course, it's more economical too because it's just a one-time subscription. So after 6 months, you will have to subscribe again, and you'll have to pay that amount again if you want to access the classes and the quizzes, etc., and clear your doubts. For 12 and 24 months, of course, you all have the buffer period. Also, it is more economical because, like I said, it is more economical because of the buffer period that you get, and it's one-time subscription. And nobody at the end of the day will ask you how long you took to clear NEET, right? Nobody really cares whether you took 1 year, 2 years, 3 years, 4 years. It's all about practice. So even clearing your exam is all about practice and revision. So that's what you guys need to do. So we'll get on with today's topic. I think I will revise yesterday's topic with you all first, because then there will be a better flow, I feel, of the subject. So we'll just go through it quickly. Okay, so just a sec, guys. Sorry. Yeah, so this was yesterday's topic. So this was basic history. That in 1999, the ISA said that capnography is a desirable standard and should be incorporated into anesthesia monitoring. Then the various terminologies that we studied, that we dealt with yesterday. So we dealt with the various terminologies yesterday. So it was basically the capnometry is the measurement of carbon dioxide in a gas mixture. Capnometer is the device that performs the measurement. Capnography is a recording of the carbon dioxide concentration versus time. Capnogram and capnograph is the actual waveform that is displayed. So capnogram is the actual waveform and capnograph is the display of the waveform, right? Then we have oxygenation. So it is measured by pulse oximetry. So it is a non-invasive measurement, percentage of oxygen in, basically pulse oximetry is a non-invasive measurement like capnography. It is the percentage of oxygen in the red blood cells. With pulse oximetry, the changes in ventilation take minutes to be detected. It is affected by basically motion artifact, poor perfusion, and some dysarrhythmias, right? So these are the things that, so basically any motion, so with capnography, the changes with ventilation, so we'll come to that, the comparisons are there. Capnography provides information about your uh, so capnography provides information about carbon dioxide production, pulmonary perfusion, alveolar ventilation, respiratory patterns, and elimination of carbon dioxide from the anesthesia circuit and ventilator. So the end-tidal carbon dioxide is measured by partial pressure, millimeter of mercury, or volume percent. It is a breath-to-breath measurement, provides information within seconds. With your pulse oximetry, it takes at least a few minutes, like we studied. This is within seconds. It is not affected by any motion. So basically, when the finger moves, the pulse oximeter reading goes. Then it is not affected. Uh, it is not affected. It is not. It is not affected by. It is not affected by motion artifact, poor perfusion, or dysarrhythmias. Okay, so basically, when a pulse oximeter, basically when the finger is so when your finger is moving, and so any motion artifact, poor perfusion, or dysarrhythmias. Um, so with the pulse oximeter, basically, so any if there's hypovolemia, the reading will not show. If there are any dysarrhythmias, if there are any arrhythmias, again the pulse oximeter reading will be distorted. And of course, with capnography, all this does not occur. So any motion, nail polish, etc., will affect your pulse oximeter reading, but it will have no effect on the capnography reading. So these are the differences. Oxygenation is oxygen for metabolism, ventilation carbon dioxide, SpO2 measures oxygenation, EtCO2 measures ventilation. Oxygenation reflects changes in oxygenation within 5 minutes. Basically, the SpO2, the pulse oximeter reflects changes in oxygenation within 5 minutes, whereas your EtCO2 reflects within 10 seconds. So why do we need capnography? It basically helps in the diagnosis of hypoxia and enables measures to be taken quickly. Now, capnography, basically in studies done by the ASA, American Society of Anesthesiologists, capnography and pulse oximetry, when used together, were effective in preventing 93% of anesthesia mishaps. So why do we need pulse oximeter? Why do we need capnography for non-intubated patients? So basically, it helps in non-intubated patients. It helps to assess the respiratory disorders like asthma, COPD, and also helps to gauge the response to treatment. So the waveform will be in one particular way with asthma. After treatment is instituted, the waveform will of course change. Then also to gauge the severity of hypoventilation state, so any drug intoxication, congestive heart failure, sedation, stroke, head injury. So these patients, these conditions can cause hypoventilation. So if in a non-intubated patient, when hypoventilation is detected in such patients, you can maybe say that, oh, something is wrong maybe in this direction. Then it also helps to assess perfusion status and non-invasive monitoring of patients with TK. Now, carbon dioxide transport, this is important. 60% is transported as bicarbonate, 10 to 20% binds to the amino group of proteins, namely hemoglobin, that is your haldane effect it produces, that 10 to 20%, and 5 to 10% is directly dissolved in plasma. So this breakup of carbon dioxide transport is very important for you all, even from physiology point of view. So it is important for you all as such, not just from the exam point of view, but to know from medicine point of view. But from the exam point of view, very important. So the N carbon dioxide, EtCO2, is basically, this is the, so basically from the, this is just showing the how the blood is oxygenated. So carbon dioxide in the arterial blood is given by PaCO2. Normal range is 35 to 45. In the mixed venous blood is PeCO2, that is 46 to 48. And exhaled carbon dioxide is, that is your end-tidal carbon dioxide, EtCO2. Normal range is 35 to 45. Now your end-tidal carbon dioxide, so it reflects changes in ventilation, movement of air in and out of the lungs. Diffusion, that is exchange of gases between the air-filled alveoli and the pulmonary circulation. And perfusion, that is circulation of the blood. So that is the what we showed in the diagram. So it reflects all these changes, basically ventilation, diffusion and perfusion. Perfusion not so much, but it still represents. So these are some of the conditions associated with ventilation, perfusion and diffusion that can be seen. So the alveolar arterial gradient, the arterial to alveolar difference for carbon dioxide, basically so when the PaC, basically that is your difference between the alveolar and the arterial concentration of CO2. So end-tidal carbon dioxide, so the normal gradient, so usually the normal gradient of, this is also important, the normal gradient of EtCO2 is 2 to 5 millimeter less than the PaCO2, right? So PaCO2 and EtCO2, we saw it was around the same range, but it is actually 2 to 5 millimeter less. So if a patient has a EtCO2 of 44, so the limit is 35 to 45. So if it is 44, you can expect the PaCO2, that is the blood arterial, the arterial blood carbon dioxide concentration to be 4 to 5 millimeter, 2 to 5 millimeter higher. Wider differences are found in these conditions, that is abnormal perfusion, ventilation, incomplete alveolar emptying, poor sampling, and negative AA gradient is seen with pregnancy, infants and children, after bypass. So these basically hypovolemic states and hyperventilation states. So basically your carbon dioxide absorption, your carbon dioxide monitoring is based on the Raman effect, which states that the transfer of energy between molecules, the transfer of energy to a molecule basically affects vibration that exists between the bonds of the atoms in a molecule. So absorption of radiation at a particular wavelength is associated with a specific type of bond between atoms in a, so a specific bond will absorb only a specific radiation. And with capnometry, infrared radiation is the one which is absorbed basically by carbon dioxide. So the non-polar molecules like helium, oxygen, nitrogen do not absorb infrared radiation. Infrared radiation is only absorbed by polar molecules like carbon dioxide, nitrous oxide, etc. So energy of radiation is proportional to the frequency of radiation. So the transfer of energy between the radiation and molecules, anyways, this is not important. You just need to remember that Raman spectrography is the principle used, and how it works I've just explained to you all. So basically the sample gas basically that is exhaled by the patient is aspirated into an analyzing chamber where infrared light illuminates it, and through a argon laser beam the light is absorbed by the molecules in the gas, in the sample gas. It absorbs the molecules because it is carbon dioxide, it can absorb infrared light. So at a particular wavelength this light will the molecules in the sample gas will absorb this light, and which leads to a vibration or rotational energy in these molecules, and the scattering, and produces scattering because of this. Basically it is measured, so it produces vibration. So this vibration, basically this movement is measured at right angles to the laser beam of infrared radiation, and this is displayed in the waveform, and the gas can be known. So measurement of respiratory gas is usually done by infrared analysis, like we discussed yesterday. And infrared analysis basically it is through two analyzers, mainstream and side stream analyzer. And infrared analysis are based on the principle that gases with two or more dissimilar atoms in the molecule. So gases like carbon dioxide and nitrous oxide, two dissimilar atoms, have unique infrared light absorption spectra. So each one has a unique wavelength at which it will absorb infrared light. So since the amount of infrared light which is absorbed is proportional to the concentration of the absorbing molecules, the concentration can be determined by comparing the infrared light absorbance in the sample with that of a known standard. So basically they say that the amount of infrared light that is absorbed by the molecule is actually directly proportional to the concentration of the absorbing molecules. So by measuring by the concentration can be determined by comparing the amount of infrared light absorbed to a known standard. So it is compared to the amount of infrared light that is absorbed by the molecules to a known standard. So some of the advantages and disadvantages are volatile agents can be measured by this method. There is no need for scavenging. It is portable. These analyzers are portable, quick response time. Anyways, we'll come to that. Yeah, so now this is your side stream analyzer. So basically your side stream analyzer is through the infrared light source, like you can see. So in your side stream analyzer, basically through this infrared light source, the light passes through a chopper wheel which has filters of a particular wavelength of that is fed in about the sample gas. So the carbon dioxide, the filter paper will have that wavelength and it passes through that, and this passes, the infrared light passes through a reference chamber and a sample chamber. So the sample chamber, basically the sample gas enters through the sample chamber, the infrared light passes and it is displayed on a photo sensor. Now an electrical current is passing through the photo sensor. So this filter will basically the filtered pulse light is passed through the sample chamber and reference chamber. Okay, the light is then focused on the photo sensor which is at the bottom, and the amount of light absorbed by the sample gas is proportional to the partial pressure of the so the amount of light that is absorbed by this sample gas is proportional to the partial pressure of the gas which is there in the filter, which is fed into the is basically proportional to the infrared light absorption patterns uh, corresponding to the wavelength selected on the filter. So whatever wavelength for gas is selected on the filter, this will correspond to that. So these analyzers are made for that particular gas basically. So the electrical current passing through will produce a display. This is your side stream analyzer. So the advantages are, it is easy to connect, no problems with sterilization, can be used in a awake patient, easy to use when patient is in prone position, and can be used in collaboration with the simultaneous oxygen administration via a nasal prong. However, the disadvantages are there can be some delay in recording because there is a sampling port, right? So there can be some delay in the recording coming up. There can be sample tube obstruction because it is another tube, and water vapor pressure changes affect carbon dioxide concentration. So any water vapor pressure changes will affect the carbon dioxide concentration. So any water vapor that collects in the sampling tube can clog the tube. Now the pressure drop along the sampling tube affects, so any pressure drops along the sampling tube will affect sampling, right? Now this is your mainstream analyzer. So basically your mainstream mainstream analyzer basically has, so your mainstream analyzer basically has it has a cuvette. That transparent thing is known as a cuvette, which has two windows which are opposite to each other. So this is your cuvette. Okay, and this is basically your analyzer. So this analyzer has basically both the it has the source as well as the sensor to sense. So basically from one side like this. So it has a source as well as the infrared detector. So from one side the infrared light will pass through a chopper wheel which has 3 holes, and the infrared light will be detected and will be displayed. So mainstream, basically there is no sampling tube, hence no obstruction. There is hence no effects with pressure drop, no effects with water vapor, no pollution, no deformity of capnograms due to non-dispersion of gases, and no delay in recording because there is basically no sampling tube. However, these sensors are very bulky and can cause traction on the endotracheal tube. And they have a long electrical cord which can, come in the way, and it can be quite hazardous. Sensor windows can clog with secretions, and if replaced, it is quite expensive, the sensor, and it is difficult to use in patients in prone position because of the weight. So this is basically your side stream and mainstream analyzer, what we just discussed. So chemical method of carbon dioxide concentration, basically it has a window in the middle, like you can see. This is the window in the middle. So basically two types are there, hygroscopic and hydrophobic. Hydrophobic is not used. The hygroscopic carbon dioxide detector, chemical detector, is basically used. It consists of a hygroscopic, basically hygroscopic filter paper that is impregnated. So this is the hygroscopic filter paper which is impregnated with a colorless base and an indicator that changes color uh, as a function of the pH. So this will change color as a function of the pH. This is impregnated hygroscopic paper impregnated with a colorless base. So basically a mauve color indicates this indicates a low level of carbon dioxide, less than 0.5%. This beige color B, which will indicate a moderate level of carbon dioxide, around 0.2 to 2%, and a yellow color indicates a high level of carbon dioxide, more than 2%. Minimum range for carbon dioxide detection is 0.25% to 0.6%. Again, okay, the advantages are basically it's easy to use, compact, for soon after resuscitation to know the endotracheal tube placement. It is very effective. It is disposable, so it is hygienic. It has to, the cost is low. Um, uh, it can serve to evaluate resuscitation, esophageal intubation. It has minimum resistance to flow and does not always require cleaning, and it minimizes the risk for infection transmission. The disadvantages are the patient has to take several breaths before there is any indication. So in cardiopulmonary resuscitation, it does become difficult because the patient is not taking enough breaths, and also false negative results have been shown. Um, uh, a, a, a positive test during cardiopulmonary resuscitation will indicate that the tube is in the airway, but a negative result does not mean that it is not in the airway, right? So it is difficult sometimes in distinguishing color changes. So it may be, if the color change is subtle, you may require a different method. So these are some of the disadvantages. So effect of atmospheric pressure, basically it has to be, the capnometer has to be adjusted according to atmospheric pressure, and because it causes errors. Water vapor too causes errors as it may condense on the window of the sensor cell, okay, and give a falsely high carbon dioxide readings. So there are two types of capnographs, your volume capnograph and your time capnograph. Volume is not so much used. The volume basically gives the volume of carbon dioxide exhaled per breath, okay, and basically calculates the exhaled carbon dioxide and respiratory dead space, not much in use. This is your normal time capnograph, and this is what we will be discussing today. So let's get on with it. Again, like I said, use my code at the bottom of the screen to avail your 10% discount. So you all will get 10% discounts if you all use my code SASHA before subscribing. Okay, so like you can see here, it is 30,000, it becomes 27,000. All these have a 10% discount. So kindly use my code. Okay, so now coming to the today's class. So we have revised, so we know what we will be dealing with today. So let's get on with class. So this is the normal capnographic waveform, right? So normal waveform of one respiratory cycle. This is a normal waveform. It is very similar to ECG. The height shows the amount of carbon dioxide. The length, so this depicts time. The height shows the level of carbon dioxide. Okay. Capnographic waveform on screen and printout may differ in duration. So on screen, the capnograph waveform is condensed to provide adequate information. The 4-second in the 4-second view. So it is a time to time analysis on screen and it provides adequate information in 4-second view. Printouts are in real time, so you have to compare the ECG RR. The capnographic waveform. So the capnograph detects only carbon dioxide. So basically it detects only carbon dioxide from ventilation. No carbon dioxide present during inspiration, and baseline is normally 0. So baseline is usually 0. So when there is a graph, so I'm sorry. So this has to touch the baseline. Okay. Like this. So this is what they mean by it has to touch the baseline. So basically metabolism monitoring carbon dioxide elimination gives an indications of the patient's metabolic rate. So monitoring of this end-tidal carbon dioxide gives an indication of metabolic rate of the patient, right? So an increase or decrease in end-tidal carbon dioxide, uh, but this is only in mechanically ventilated patients. Okay, so only in mechanically ventilated patients, an increase or decrease in carbon dioxide gives an indication of metabolism. So basically, this patient is on ventilator, right? So you don't know what the way the patient is breathing, what happening in the body of the patient. So this increase or decrease on the waveform gives an indicator. It is an indicator of metabolism in mechanically ventilated subjects. But for spontaneously breathing subjects, the EtCO2 may not increase with increased metabolism because there will be subsequent hyperventilation, right? So hyperventilation in hyperventilation in spontaneously breathing subjects can alter the increase or decrease, right? So carbon dioxide can also be increased, during laparoscopic surgeries when carbon dioxide is used to inflate the cavity. So that time too, during a surgery, carbon dioxide can increase. Then malignant hypothermia. Tomorrow my class will be on malignant hypothermia. So it is a hypermetabolic state, and the increase occurs early. That is the first sign. Then so the carbon dioxide curve has to touch baseline. Then okay, so now coming to the phases of this carbon dioxide monitoring, right? So we have to read about the phases of this carbon dioxide monitoring. So as you can see, just a sec. So this is your baseline basically. Okay, so this is your curve. So you have AB. So AB is your baseline. This is the beginning of exhalation. So this, the waveform begins with exhalation. So it begins with expiration basically. Okay. So it begins with expiration. So that is your baseline, begins with expiration. AB. So remember this. AB is the beginning of exhalation. Okay. Then so basically this waveform, it should be examined. Okay, so the waveform, when we are looking at the waveform, it should be examined for basically height, frequency, rhythm, baseline, and shape. So we saw that it has to touch the baseline, so it has to be examined for the height, the frequency, the rhythm, the baseline, and the shape, right? So the waveform should be frequency. Basically the frequency depends on the respiratory rate. Then the baseline is normally 0, like we discussed. The baseline is normally 0. So an elevated baseline, an elevated baseline can result from administration of carbon dioxide, rebreathing, exhaustion of the absorbent, contaminated sample cell, or an incompetent expiratory unidirectional valve. So when is the baseline elevated? I will show you that graph, and again we will go through. So the baseline can be elevated when carbon dioxide is administered, or there is rebreathing. So rebreathing, carbon dioxide is administered, then absorbent is exhausted, carbon dioxide absorbent is exhausted. Then during when there the expiratory, this is important, remember this, expiratory valve of the ventilator is faulty. Okay, so faulty expiratory valve, so the baseline will be elevated. So the shape of the normal waveform is like we saw, only one shape is considered normal. So only this one shape, that is the your top hat or sine wave. Okay, this is the shape, top hat or sine wave. So only this waveform is considered normal. No other waveform is considered normal. There will be some problem in any other waveform, right? So phase 1, so we will come to the phases, but this is your baseline. AB, this is the of your graph, this is your baseline, beginning of exhalation. Phase 2, that is the ascending phase, that is your early exhalation. Okay, so carbon dioxide present and increased in exhaled air. So this is your early, this is the ascending phase, this is your phase 2. So basically in the phase 2, it's an expiratory upstroke. Okay, so your phase 1, okay, this is your phase 1 also, this is also known as phase 1. It's beginning of exhalation, but it is also the end of expiration, also known as your inspiratory baseline. Okay, it is also known as inspiratory baseline. It is normally 0, and it reflects the, basically this is 0, it basically reflects the inspired gases that are present there. before exhalation begins, and it represents that there is no carbon dioxide in this gas at this phase, right? Because expiration has not yet started, it is still inspired gases. Now your phase 2, that is your ascending phase. So basically in this phase, it is a expiratory upstroke. So it is an expiratory upstroke, right? It's an expiratory upstroke, and it's a rapid S-shaped upswing. Okay, it's a rapid S-shaped upswing. So it's a rapid curve upwards, and it represents the transition from the gas from the dead space that does not participate in gas exchange and alveolar gas. So it is basically a transition from dead space gas to alveolar gas. So basically this transition, so the dead space gas has no carbon dioxide, and whereas your alveolar gas has carbon dioxide. So it basically shows a transition. It is a rapid transition. So the transition from the dead space gas with no carbon dioxide to alveolar gas with carbon dioxide. Now your phase 3 is basically your alveolar plateau. Okay, that is between C and D. Uh, Phase 3, it begins at C and continues just before D. So as the gas is almost entirely from the alveolar. So this gas is almost entirely from the alveoli and hence it forms a plateau. Yeah, it's almost indirectly from the alveoli. Plateau is normally seen. If a plateau is not seen, the maximum value obtained may not be equivalent to the entitled carbon dioxide. Okay. Uh, the slope of this phase is increased by ventilation, perfusion abnormalities in the lung, as well as external factors such as King tube. So it's basically a plateau. But when this C and D, the slope gets increased like this, when it is not a plateau, it basically indicates ventilation, perfusion, mismatches. More importantly, it indicates a kinked, because it's indicating an obstruction, kinked tracheal tube. So even in bronchospasm, it's basically, this is the pattern you will see, a shark fin pattern, because it is indicating an obstruction. So kinked tracheal tube also indicates an obstruction. So this is your capnogram. This is your basically your phase 3. That is your in your phase 3 only. The very last portion of the phase 3. It is referred as an end tidal point. So the carbon dioxide level here is at its maximum, and in normal individual it is 5 to 5.5% or 35 to 40 torrs. So this point D is basically the end tidal point. The carbon dioxide level here is maximum. Okay. So your carbon dioxide level here is maximum. So this is the end tidal point. Carbon dioxide level is maximum. It is the end of the wave of exhalation, contains the highest concentration, and it is usually 5 to 5 point, sorry, yeah, 5 to 5.5%, or 35 to 44 torr, that is millimeter of mercury. Okay, so remember this point D. Now the phase 4. So the phase 4, that is your descending phase. Basically, inhalation begins, oxygen fills the airway, carbon dioxide level quickly drops to 0. So this is your phase 4, inspiratory downstroke and returns to baseline. Okay, now coming to this, these are some of the angles. So now we studied about, this is your expiration, inspiration, this is the highest point of your EPCO2, this is your dead space ventilation, basically no carbon dioxide. This is a transition, upstroke is a transition from your dead space to your alveoli ventilation, from no carbon dioxide to carbon dioxide. Now, so basically your angle between phase 2 and 3 is called the alpha angle. So alpha is angle between phase 2 and phase 3. So this is phase 2 and this is your phase 3. So your alpha is the angle between phase 2 and phase 3. It is also known as the takeoff or elevation angle. Takeoff or elevation angle. It is normally between 100 and 110 degree. Normally between 100 and 110 degree. It is decreased with obstructive diseases of the lung. So obstructive diseases. So the slope of phase 3 depends on the lungs ventilation perfusion status, airway obstruction and PEEP. So basically this angle will be decreased with airway obstruction. This alpha angle, right now we are talking about the alpha angle, will be decreased with airway obstruction, and this up, you will see an upslope, right? So this angle, this upslope is basically seen with again airway obstruction. The slope of the phase 3 depends, like I said, the lung ventilation perfusion status and airway obstruction. The slope will be increased, right? Oh, I'm sorry, forgot. We have discussed it last time. So the angle between phase 3 and the descending limb. So between phase 3 and this descending limb, basically your beta angle, right? It's called the beta angle. It is approximately 90 degree, and it is the angle is increased with the rebreathing. Okay, it's written there. See that rebreathing. So this indicates your ventilation perfusion, and this will indicate your rebreathing. So this angle will get increased with your rebreathing because there is more entitled carbon dioxide present. Uh, there is another possible cause can be so if the slope of phase 3 is increased, the slope of phase 3 is increased, the beta angle will decrease. So with ventilation perfusion, as the slope increases, the angle decreases. Here also, as the slope increases, the angle will decrease. Okay. So the inspiratory segment phase 0 inspiration, beta angle between phase 3 and the descending line of the inspiratory segment approximately 90 degree, and alpha angle is between your phase 2 and 3 is usually around, the alpha angle is around 110 to 110. This is your expiratory segment. This is very important, that's why it's so much of this. So phase 1 is your anatomical dead space. Your phase is basically the anatomical dead space. Phase 2 is a mixture of anatomical and alveolar dead space. Phase 3 is the alveolar plateau, and the alpha angle is the angle between phase 2 and phase 3. It indicates the ventilation or fusion status of the lung. So this is a normal capnographic waveform. So like we discussed in the previous class, capnography can be expressed as a function of volume percent or millimeter of mercury, right? That's how we discussed that it can be expressed. So over here, the normal range, as you can see, this is the normal waveform, and the normal range is 35 to 45 millimeter of mercury, and this is the normal waveform. So coming to hyperventilation capnographic waveform pattern, this is hyperventilation and hypoventilation. Just a sec. So basically with your hypo, the so with your hypoventilation, so as you can see, this is a normal from 0 baseline, this is your baseline, up to 45 millimeter of mercury. So the normal is 35 to 45 millimeter of mercury. Okay, so as you can see, elevated entitled carbon dioxide with good alveolar plateau. So this is a good plateau. It can be so this is an elevated carbon dioxide level with a good plateau. So elevated carbon dioxide level with a good plateau, right? So an elevated carbon dioxide level with a good plateau basically indicates hypoventilation, right? So there is increased ethyl CO2 because there is the decreased flush out. Basically the patient is hypoventilating, not ventilating enough, so there will be a build-up of carbon dioxide, but as you can see, the plateau is very stable. In hyperventilation, as you can see, there will be short waves, there will be decrease in the EtCO2. Okay, there will be a decrease in the EtCO2 because rapid shallow breaths, and there will be no touching of baseline, as you can see. Because rapid shallow breaths, so there is no time to return to baseline. So your capnography provides 3 sources of information. Basically, it provides your EtCO2 value, the shape of the capnogram, and the arterial to the alveolar PCO2 difference. Okay, so it basically provides your EtCO2 values, shape of the capnogram, which will tell you about basically about any abnormal condition, and your alveolar arterial PCO2 difference. So these are some of the conditions where the alveolar arterial so the alveolar arterial gradient, as you can see, so there are various conditions that will affect your that will affect the gradient of alveolar dead space. So as you can see, just a sec. So in this alveolar arterial PCO2 difference will increase with age, emphysema, low cardiac output states, hypovolemia, pulmonary embolism, right? Then with the it and you can, this gradient decreases with pregnancy and children. So the gradient will be low with pregnancy and children, but it is also decreased, with rebreathing. So rebreathing also decreases it. Or any malfunctioning of a non-rebreathing valve. So functioning of then any obstruction in the breathing system to expiration, sorry. Okay, so it basically upper airway obstruction, it will increase. So increase is seen with upper airway obstruction. There is no change with hyper and hypoventilation. Okay, so no change with hyper there is no change with hyper and hypoventilation, and it can be elevated with upper airway obstruction, uh, high sampling rate, inadequate. So if there is an inadequate seal around the tube, the end tidal to arterial gradient will be elevated. Okay, so uh, air thrombus, increased dead space, it will be elevated. So hypovolemia, emphysema, because these all emphysema is a high dead space. There is more dead space, right? Age-related pulmonary embolism, inadequate seal around the tracheal tube, upper airway obstruction. In all these cases, it will actually be elevated. Then, of course, there is a decrease in is seen with pregnancy and with in children. Then rebreathing, malfunction of non-rebreathing valves, obstruction to expiration in the breathing system. So with all these, you will see a decrease in the end tidal to arterial gradient. There is no change, like I said, with hypo and hyperventilation. So there will be no change with your hypo and hyperventilation. Now, five characteristics of capnogram. The shape of a capnogram is identical in all human beings with healthy lungs. So this is the characteristic of a capnogram basically, and these five, like I said, should be evaluated. We discussed this already. So the shape is identical in all human beings with a healthy lung. Any deviation in shape must be investigated to determine physiological or pathological causes. Frequency, rhythm, height, baseline, and shape have to be examined. We dealt with each of these. Frequency basically corresponds to your respiratory rate. so frequency corresponds to the respiratory rate. Then your baseline should be 0. Shape has to be top hat or sine wave form. Okay, and height depends on the EtCO2, the level of EtCO2 and comorbidities, and the rhythm is all, of course, a beat to beat measurement. So this is seen with your resuscitation basically. So this is your resuscitation trend. Okay, so during resuscitation, this is basically because of the cardiac, oscillations. Okay, that basically pressure on the heart during resuscitation will cause that. Of course, there are similar trends to this which are seen, which I will tell you right now. So one is so in this graph, if there is a sudden drop to 0, okay, so there will be oscillations produced like this, and then suddenly you will see a drop to 0 like this. Okay, so this sudden drop of N-type carbon dioxide to 0 is usually caused by an acute event which is related to the airway. So it can be due to extubation, esophageal intubation. So initially, because of the acidity in the stomach or some gas during ventilation might have passed into the stomach, so initially you will get a waveform. So esophageal intubation, I'm doing this here because it is very similar to this. Then disconnection, any disconnections. So initially it's reading well and suddenly there's some disconnection in the circuit. And ventilator malfunction. Any plug, the gas sampling line getting clogged. So basically the sampling line getting clogged, or complete obstruction of the totally obstructed tracheal tube. Yeah, so these can be the causes for this type of waveform. Then this is a sudden decrease. Now an exponential decrease. Okay, an exponential decrease. So this is your waveform. So an exponential decrease. Okay, an exponential decrease is due to sudden hypotension due to massive blood loss or obstruction. So any sudden hypotension due to massive blood loss or blockage of sudden hypotension, or any blockage of a major blood vessel, circulatory arrest. So basically any circulatory arrest. Any circulatory arrest because with the basically with the pulmonary embolism. Okay, so this will be your pattern. Okay. It can also be because of if the tracheal tube is poorly fitting, or there is partial disconnection. There is a mild disconnection in the breathing system, not complete disconnection. So with the complete disconnection, you will see a sudden drop. So any partial disconnection, or if the tracheal tube or mask is loose, you will see such a pattern. So in pregnant subjects, basically, in a terminal upswing at the end of phase 3, as you can see, at the end of phase 3, a terminal upswing, this is also known as phase 4, can occur in pregnant and obese subjects and low compliance states. So this can be seen like during positive pressure ventilation, a leak in the sampling line. So a leak in the sampling line, during intermittent positive pressure ventilation. So any leak in the sampling line. So a plateau of long duration is followed by a peak of brief duration. The height of the plateau is inversely proportional to the size of the peak. So height of plateau is inversely proportional to size of peak. So higher the peak, higher the size of peak, smaller is the height of the plateau. The brief peak is caused by the next inspiration. So the brief peak is due to the next inspiration. Okay, it's due to the next inspiration when positive pressure ventilation transiently pushes the undiluted entitled gas through a sampling line, right? If the patient is breathing spontaneously, a low carbon dioxide, a low EtCO2 reading may be seen owing to air entrapment. Okay. So basically, this is due to the next inspiration. So when the positive pressure ventilation basically pushes the undiluted and carbon dioxide gas. So whatever there is, the next inspiration has started, and whatever undiluted gas is there at the in the sampling line, the next inspiration will push it into the sampling port, and that peak will be seen. So this may be due to a leak in the sampling line, pregnancy, obese patients, and the height of the plateau is inversely proportional to the size of the peak. Now your baseline is basically elevated in if there is inadequate fresh gas flow, accidental administration of CO2, rebreathing, uh, inspiratory by expiratory valve malfunction, and exhausted carbon dioxide absorber. Okay, the waveform will be normal in shape. Okay, the waveform will be normal. So normal waveform. Normal waveform. So there is basically, now the inspiratory valve, not always, sometimes. Okay, expiratory valve, whenever it is incompetent, there will be definitely an elevation of baseline, but inspiratory valve, not always elevation. This elevation of baseline will be seen, but with the expiratory valve incompetence, this elevation is always seen. Okay, this elevation in baseline is always seen. So any deliberate addition to carbon dioxide in competent inspiratory valve, it may be also due to rebreathing under drape. So rebreathing, there will be an elevation of the baseline. So expiratory valve malfunction, like we discussed, it can result in prolonged abnormal phase 2 and phase 0. Now the inspiratory valve malfunction, as you can see, there is elevation of the baseline and prolongation of downstroke. So this will be prolonged. So there will be a prolongation of the downstroke. This elevation of baseline need not always be there. Unlike with the faulty expiratory valve, elevation of the baseline with a faulty inspiratory valve need not always be there, but there is a prolonged downstroke that can be seen, right? And So on the volume curve, that is your PCO2 here and volume of carbon dioxide here. So your the normal curve for your thing is, sorry, the normal slope is something like this. Okay, I'll draw it again. So the normal slope is something like this. This is normal. But the abnormal is, there will basically be a decreased downstroke on the inspiratory side. So it will be like this, same thing. The downslope will be decreased. Okay, so a decreased downstroke on the inspiratory side. This is your volume loop. Now, like I said, with your hypoventilation, we discussed this earlier. There's gradual elevation of the height of the capnogram, baseline remaining at 0. So the baseline remains in 0. Baseline is 0, but there is the elevation of height. Basically, your EtCO2 will be increased. Hyperventilation. Now, with hyperventilation, there is a gradual decrease in the height of the baseline remains at 0. And there is a gradual decrease in height. Right? Now, esophageal intubation, like we discussed briefly. So, esophageal intubation, there will be a sudden drop of entitled carbon dioxide to 0. This is your thing. I do it that time. So, this is, suppose I'm just drawing roughly, not the proper waveform. And there will be a sudden drop like this, right here. So, this sudden drop. This is because, so initially, because prior to intubation, you will ventilate the patient. So, there will be some ventilated gas in the stomach. Or there can be maybe if some acid is there in the stomach, some acid ingestion or whatever, or some drugs in the stomach which can increase the acidic content. So this will initially be perceived as EtCO2 because of the ventilated gas, or if there is any acid in the stomach. So it will be perceived as EtCO2. So initially you will find a waveform, then finally obviously there is no, it is not the lung, so there is no EtCO2 production, there is no carbon dioxide production, so you will find a sudden dip. So this indicates your esophageal intubation. It is very useful during cardiopulmonary resuscitation because when it's a big, it's a lot of confusion when a patient collapses and the patient is resuscitated, and this is the method of confirmation. The EtCO2 is the method of confirmation of placement in the trachea. But it is not foolproof. See, because esophageal will not immediately show that yes, it is not in the trachea. It's not like there will be a flat line immediately. There can be a response. So the graph has to be monitored initially, right, to see the pattern of the graph, etc., to know whether it is esophageal or within the trachea. Now coming to cardiogenic oscillations. So it is a ripple effect superimposed on the plateau and the descending limb, resulting from small gas movements produced by pulsation of the heart and the aorta. So basically that's what the cardiac oscillations are. Because of pulsations of the heart and the aorta, you can see these small movements which start from the plateau phase and superimposed on the descending phase. So it appears like tooth-like humps at the end of expiratory phase. So tooth-like humps. at end of expiratory phase. At the end of expiratory phase, tooth-like humps, they be single or multiple. Single or multiple. Height varies. Okay. It is because of the beating, it's basically due to the beating of the heart against the lungs. So this is another explanation. Beating of the heart against the lungs. So basically the pulsations of the heart and the aorta against the lungs. A number of factors contribute to the appearance of cardiogenic oscillations. Basically, the factors which contribute are your intrathoracic negative intrathoracic pressure, negative intrathoracic pressure, low respiratory rate, decreased vital capacity, heart size ratio, a low inspiratory expiratory ratio, low tidal volumes, muscular relaxation. So in many cases, if you adjust the ventilator rate, the flow, the tidal volume, basically if the ventilator rate is low, the flow is low, tidal volume is low, this will be seen. So if it is adjusted, it will remove this pattern from the screen. Other times, however, it cannot be corrected many a time. So the cardiac oscillations in a pediatric patient are a rule rather than expectation. So so the cardiac oscillations, they are the rule rather than the exception in the pediatric patients. So there is an exception in the pediatric patients because the relative size of the infant's heart and thorax. So capnogram from patients with emphysema will not, so patients with emphysema will not register these cardiac oscillations. They will be less prominent. So cardiac oscillations can also result from component positioning in the breathing system. So any HME, so basically if you place the sampling site on the side of the HME, so on the side of the HME filter, on the patient side of the filter. So the HME filter faces two sides. One is the patient side and one is the machine side. So if this sampling port is placed on the patient side, it may remove the oscillations. Now coming to airway obstruction and bronchospasm. So as you can see, obstruction in airway or the breathing circuit. So partially kinked or occluded artificial airway. So presence of foreign body. So the possible causes for this type of capnogram. So it can you see the shark fin pattern? It is known as shark fin pattern. So this is the shark fin pattern. Okay, this is the shark fin pattern. So partially kinked or occluded artificial airway, basically your endotracheal tube. So during bronchospasm, the phase 2 and phase 3 are prolonged, and alpha angle between the phase 2 and phase 3, this is your alpha angle, is increased. Basically your alpha angle will be increased. This phase, the plateau is prolonged. I'm sorry, alpha angle increases, not decreases. I said decreases earlier. The alpha angle increases. It's common sense. I'm sorry. Presence of foreign body in the airway, again causing obstruction. Obstruction in the expiratory limb of the breathing circuit, again obstruction, and bronchospasm. So these are the ones which will cause basically cause obstruction to the breathing system. Will cause this pattern. So as you can see, the shark fin pattern. Just a sec. Sorry. So here, yeah, sorry. This is your shark fin pattern. Shark fin pattern, which is basically seen with your bronchospasm. Kink to the tracheal tube. Any obstruction in circuit, etc. Now this is your curar cleft. It indicates return of spontaneous circulation, spontaneous breathing. So curar cleft or notch, curar cleft or notch. It is seen during spontaneous ventilation. Seen during spontaneous ventilation. The capnogram, so as the muscle relaxant is reversed, the curve becomes normal in shape. Okay, so if muscle relaxant is given, the next waveform will be normal in shape. There will be no cleft. This is after the muscle relaxant is given. So the cleft is present in the last third of the plateau and is caused because of lack of synchronous action between the intercostal muscles and the diaphragm. So it is seen in the last third of the plateau. And the cause is basically lack of synchronous action between intercostal muscles and diaphragm. So when the spontaneous respiration is returning after muscle relaxation due to the lack of synchrony between the intercostal muscles and diaphragm, this is seen. So it is caused by inadequate muscle relaxant reversal. The depth of the cleft is proportional to the degree of paralysis. So the depth of the cleft is proportional to degree of paralysis. Right? So the depth of the cleft is proportional to the degree of muscle paralysis, and the position of the cleft is fairly constant on the same patient, but not necessarily present with, it might not be present with every breath, but the position is fairly constant in the last 1/3 of the plateau. The notch is also seen in patients with cervical transverse lesions. So in patients with cervical, these are the other places where it can be seen. Cervical transverse lesions, flail chest. This is important for you all to know where else this curate cleft can be seen. Flail chest, hiccups, pneumothorax, okay. So these are the conditions where it can be seen. So it appears when muscle relaxation begins to subside. The depth of the cleft is inversely proportional to the drug activity. Right? So the depth of the cleft is directly proportional to the degree of drug activity. So malignant hypothermia. So Basically, as you can see, this is a situation. You have just intubated a patient that has severe dyspnea during using rapid sequence successfully. This is your BP, 140 by 90, heart rate 140, respiratory rate is assisted. Now look at your sudden rise in your carbon dioxide, your sudden rise in your CO2. There is a sudden rise of 55. Your initial EtCO2 is only 55. Yes, there can be severe dyspnea, but at initial part only the EtCO2 cannot be. There is a sudden sharp rise in your EtCO2. This is highly suggestive of malignant hypothermia. Okay, so this condition is highly suggestive of malignant hypothermia. Now, with hypothermia, a gradual decrease in end-tidal carbon dioxide will be seen with hypothermia because of reduced metabolism, hyperventilation, and the leaks in the sampling system. So these are the other cause for a decrease in end-tidal carbon dioxide, that is your hypothermia. Reduced, it also indicates reduced metabolism, so there will be reduced metabolism, hyperventilation, and leaks in the sampling system. So any leaks, hyperventilation, reduced metabolism, and hypothermia will show a decrease in your end-tidal carbon dioxide. Now, as you can see with kyphoscoliosis, the carbon dioxide waveform has two humps. Okay. This is resulted in a compression of the right. Basically, this indicates that there is a restrictive disease. So this indicates the presence of a restrictive disease. So the presence of two humps in severe kyphoscoliosis. Now see, as you see this ripple effect, this is your cardiac oscillations. Sharp fin is basically your obstruction due to bronchospasm, or any obstruction in the tube, or any obstruction, kinking of the tube, or any obstruction in the machine. The curar cleft indicates your muscle paralysis and return of spontaneous ventilation, also seen in hiccups, pneumothorax, cervical transection. This is your hypoventilation. As you can see, there will be a decrease in the height. Hyperventilation, as you can see, there will be there will be actually a decrease. Hypoventilation, I'm sorry, there will be an increase in EtCO2 because of collection of carbon dioxide. Here there will be a decrease in EtCO2, but baseline, both these baseline is touched. In both these situations, baseline is touched. Then rebreathing, there will be, in rebreathing, baseline is elevated. So with rebreathing, baseline is elevated. So this is the capnogram during spontaneous ventilation intervals. You will not see a proper waveform pattern because of the hyperventilation will superimpose. So you will not get a proper pattern, of course, but this is the pattern that you will see in these patients. Okay. So sampling problems such as air or oxygen dilution during nasal mask sampling or carbon dioxide in. So this waveform is basically seen with sampling problems. So if there is any oxygen dilution, so oxygen dilution will basically decrease the EtCO2. Okay. So with nasal mask, so if the sample tube is kept next to the, it's basically kept next to the oxygen mask. So here oxygen inflow is there. So basically the carbon dioxide will get diluted, right? So because of this dilution of the carbon dioxide in spontaneously breathing patients, so it will get diluted and then cause in these patients. So detection of pulmonary air embolism, basically a rapid decrease of EtCO2 There will be a rapid decrease in EtCO2 in the absence of changes in blood pressure, central venous pressure, and heart rate. So initially there will be no changes in BP, CVP, heart rate. This indicates an air embolism and a rapid decrease in EtCO2 without systemic consequences. As the size of the air embolism increases, of course there will be a reduction in cardiac output with further decrease in the EtCO2 measurement. Okay, so the first sign will be a rapid, this is very important, a rapid decrease in EtCO2. You have to suspect a pulmonary air embolism. So these are the various waveforms in capnography. Like I said, this is your normal waveform, phase 0. Phase 1 is your alveolar ventilation, that is with your carbon dioxide and dead space ventilation with no carbon dioxide. Phase 2 is your dead space ventilation, no carbon dioxide. Phase 0. Phase 2 is the plateau phase. This is your plateau phase, purely alveolar ventilation. And phase 3 is the downstroke, where there is expiration, end of expiration, beginning of inspiration occurring, right? So this phase 0 is basically your inspiration. This is your entire thing is your expiration, and again this is your expiration decreasing and becoming inspiration. In your obstruction, you can see a shark fin tube. So any obstruction, basically your shark is biting your tube, so it produces a shark fin obstruction or bronchospasm. Asynchronous breathing, as you can see, this is a curate cleft. It corresponds basically to your, like I said, the muscle relaxant. This is during CPR. The aim should actually be for 10 millimeter of mercury, because it will be rapid. It's more like hyperventilation. Hypoventilation, you can see elevated, the baseline is touched. Hyper and hypoventilation, both the baseline is being touched. But in hyperventilation, there will be decrease in EtCO2. Hypoventilation, there will of course be an increase in your EtCO2. And then we have your sudden loss of waveform. ET tube is disconnected, or there is a sudden loss of circulation. So either your ET tube is disconnected, or you are having a cardiac, or there is a cardiac arrest, or if not a cardiac arrest, there is sudden loss of circulation. So guys, that's it for today. That was the class. We've completed the capnography part of it, and tomorrow I'll be taking class on malignant hypothermia at 7:30 p.m. So kindly do log on. I shall see you all tomorrow. Have a good day. Stay tuned. We'll meet tomorrow. Thank you guys. Do use my code SASHA and avail your 10% discount, guys. So hurry, avail your discounts, don't delay. See you all soon.